Hi, everybody. Welcome. Hope you all learned something. This is a joy of mine to do these presentations, give people information, and to share this information with your friends and colleagues, because I hope that we're going to touch on a few things that really can impact your quality of life. But more importantly, there's a couple of points in here where the fact the urologist might be able to save a life. And I noticed some of my colleagues who are cardiothoracic surgeons and trauma surgeons, they argue that, but I think I can win. Real quickly, what is BPH? So BPH is just enlargement of your prostate. Obviously, everybody knows the man only has a prostate, and it presents an obstruction option or potential issue between the bladder and the outside world. So as a man voids, he voids through the prostate. So if that's larger, it closes down that pathway, it just becomes an obstruction. So a lot of times what you'll hear us talk about as urologists is obstructive voiding and irritative voiding. So obstructive voiding is the slow stream, the starting, stopping, the can't get the urine to come out. While the irritative voiding is classified as the frequency, I've got to go a lot, urgency, I have to go all of a sudden, or getting up at night. So in that aspects, there are two different types of symptoms you can get, two types of symptoms you can get from an enlarged prostate. About 53 million men suffer from BPH. Plenty of different treatment options. So this is definitely something that we want to work on. And one of my points about saving lives is, why do I treat so much BPH? Because I really do want to make an impact on my patients. But more importantly, BPH causes people to get up at night. So one simple take-home fact is nocturia is what we call getting up at night. If you get up 3 or 4 times a night, then you're at risk for falling. And the data says if you're over the age of 70, you get up more than 1 time a night, you're at an increased fall risk. So an increased fall risk has things like broken hips, broken knees, subdural hematomas, which my mom just actually had. So this actually hits very home for me. But if you just look at hip fractures, the mortality, I believe the last time I looked, a hip fracture was about 30% in your first year. So that means just because a man is getting up at night, if he falls and breaks his hip, he has a 30% chance of dying solely because he was getting up at night, let alone the fact that you're getting up at night. A lot of times, who else is getting up at night? The spouse. So there was a great slide one time that came out with BPH, and it simply said, your husband's nocturia or getting up at night is your problem. So, so back to the slides here. So again, this is what we're talking about. Everybody can see my screen, correct? The cursor. This is the prostate sitting between the urethra, the bladder and the urethra. We'll go to the next slide. So again, one quick slide point from this slide is, a lot of men say, well, gosh, I have no symptoms of BPH, therefore I don't have prostate cancer. And that's incorrect. So number one, prostate cancer does not have any symptoms. So as part of the enlarged prostate, we're going to rule out prostate cancer. But one man can take a reassurance, or one thing a man can take a reassurance is that if you have symptoms from your prostate, enlarged, can't pee, getting up at night, slow stream, and a lot of times you've almost ruled out prostate cancer. So again, they do not correlate together. They're two independent issues with the same organ. Next slide. Okay. And again, we talked about this. Again, it's just enlargement, just benign tissue causing the bladder outlet obstruction. Let's go to the next one. Prostate also can have 3 lobes. It can have the lateral lobes compressing in on the side, and it can have the third lobe, which presses in from the bladder aspect and blocking the door. I call that kind of the knee wall scenario. In other words, if the prostate is the door to the outside world, the door can be open, it can be closed, but you can have a half a door where you have to step up and over that door to get out. And that makes it also hard for the bladder. And that's what I call kind of the knee wall or half door scenario. We talked about this. BPH is not prostate cancer. It doesn't cause cancer. Symptoms may coexist, but they typically don't. PSA, everybody knows what a PSA is. That's an enzyme we check for prostate cancer. At least I sure hope we do, because this is Movember, as they call it, awareness for prostate cancer, and get your PSA checked. Okay, next one. And again, this is another depiction of how the prostate obstructs the flow of urine out to the outside world, causing problems and the symptoms. a lot of times, next slide, the size of the prostate does not correlate to symptoms. So literally in 25 years of doing this, I've seen men in fluid retention. What I mean by that is they cannot pee at all. They have to have a catheter, and their prostate's 20 grams. That's this big. I have a friend now who actually built my house. He has a 180-gram prostate, and he has no symptoms at all. So again, this is one of those adage with a little pun that the size does not matter in this scenario. It's about the symptoms and the way the prostate obstructs. And we're going to talk a lot about that in just a second. So just some main statistics. We talk about how often this is. I mean, this is 50% of 50-year-old men. It really affects their life. About 50% of men with BPH will also suffer with concomitant erectile dysfunction or sexual dysfunction. So again, we know that if you treat your BPH, enlarged prostate, then the intimacy component is going to get better. Again, 50% of men at age 60, so there's a good number. I used to say the 50-50 rule. If you're a man and you get in the elevator, okay, and you're ashamed of the intimacy component of your life or the PN and getting up at night, I promise you that if there are two men over the age of 50, one of you have it. And that goes for both BPH and erectile dysfunction, we're going to talk about later. Next slide. And again, we do talk about, obesity is linked to enlarged prostate, so a good clean diet, avoiding that does help. So what are we going to do when a man comes to us and says, hey doc, I don't pee very well. What's my problem? So first of all, we're going to start with basic exam. We talked about a PSA. That's an enzyme to screen for prostate cancer. Obviously, we're going to symptom score. A lot of guys are, why do I have to fill this out every single time? These validated scores on the right-hand side here are very accurate in assessing each individual's man's symptoms. Everybody interprets the question differently, but if you do the test over and over, you interpret it the same way. They're very accurate, a very good tool to, number one, classify how bad your symptoms are. Number two, to follow you through treatment and how well you're responding to whatever it is you so choose. The bladder impact index, that's a little bit newer, and we talk about bladder health. Again, we're going to try to help the bladder to get empty, and by treating the BPH, then we don't get the scarring, the irritation of the bladder. That irritation manifests itself as frequency, urgency, getting up at night. You can get scenarios where the prostate will be so enlarged over so many years or decades, the bladder will just over distend so much that it'll never contract again. And I actually saw that today. So again, if you have symptoms, it's important to be evaluated. So before we go into treatment options, I'm going to talk just real quickly a scenario about what are we going to do as far as how do we evaluate. I like patients to remember three things. I'm a very common sense individual: size, shape, and pressure. Everything that we do with your prostate about evaluation, about your symptoms, and about the treatment options will come down to those three aspects. How big is your prostate? What size is it? How does it wrap around the urethra? So I often tell men, for myself, it's like you called me as your mechanic for your tractor, and you said, hey, I've got my tractor's broke. I need you to come fix it. Well, you need to tell me, first of all, is that a lawnmower, a tractor, or a D10 bulldozer? I don't know what kind of truck to bring, so I don't know the tool I need to fix it. I don't know what the problem is because I don't know the size of your engine. I don't know what you're doing with that. So what's your path you're trying to create with your lawnmower? So having the tractor size, as I like to joke, I need to know that before I know as the mechanic how to work on it. And I know it's a very somewhat, I hope, comical analogy, but it really drives home. Again, if you're a man and says, hey, I've got tons of symptoms, and you've got a 150-gram prostate, i.e., that's, let's say, the D10 bulldozer, I do not need to bring my Ford F-150 to help you. It's not going to. It's going to be a futile exercise. So knowing the size, knowing the shape, and knowing the pressure of your bladder. So what's the pressure concept? The pressure concept, how much work the bladder has to do. So there again, my 150 truck does not have enough horsepower to pull the D10 bulldozer. So I need a different tool. So if your bladder's doing tons of work, really overworked against a really huge prostate, I need a different tool which may help treat that larger prostate than if I have somebody that's got a small prostate and minimal symptoms. Okay, so what are the treatment options? So everybody knows about medicine. So go back 20 years for a second. This was a very easy discussion, and it didn't take very long. It was behavioral modifications, don't drink before you go to bed, medicines, or big surgical procedures. So when you're talking about a procedure that had 2 days in the hospital, a catheter, fluid running through your bladder, those kind of things, it was very easy to say, look, let's fail medicines first. So we had very good intentions in doing that, staying conservative, walking through steps of treating a BPH. However, what we know now is that bladder health component was missed or ignored. In other words, the bladder got damaged over time while we were treating with medicines, because the medicines just treat the symptoms and mask the symptoms. They definitely give you a better quality of life, but they don't treat the problem. There again, going back to my silly analogy, my F-150 Ford may pull that bulldozer for half a mile, but it's not going to pull it to North Carolina. So having that bladder work against that really big prostate, even though on these medicines, while the prostate was still growing, still having symptoms, was causing damage, and that resulted in some of the problems. And now we know to look at that size, shape, and pressure so that we can intervene sooner. Okay, so we're not going to touch much on this. I mean, obviously, while you're waiting, you're happy with your symptoms. We don't do anything. Typically, not what most people come to these webinars or see me for. Medications. Most people know these as Flomax, Uroxetrol, Tamsulosin, Proscar. These different medications. This is an alpha blocker. Just simply relaxes to the flow. Can be better. However, it does have significant side effects. It has dizziness, fainting, low blood pressure, can cause retrograde ejaculation. And this is the one over time has scared me more than anything else, especially as I said, disclosed my mom just had a subdural hematoma from the fall. If you're already getting up 3 times a night, and I give you a medicine that might increase your fall risk, now instead of a 30% mortality because you fell, it's higher. And my job is not to increase the complication rate for you, is to improve it. And therefore, medicines don't treat the problem, have side effects. They're not a free pass. Next slide. And the next medicine is just a medicine that actually shrinks the prostate. 1/3. So keep about this. 1/3 size reduction is what this medicine will give you. It does come at about a 6% increase in erectile dysfunction. So a lot of men do not like it for that. Again, it's daily medicine. It has side effects. It has cost. So historically, go ahead. We went straight to therapy. We didn't have any of the things that we talk about now. So now we have this whole plethora of what we call minimally invasive in-office treatment options for BPH that are extremely effective. There are choices. Again, we talked about learning about the size of the tractor, size, shape, and pressure. So one of the things that I do is called vapor water therapy. Also, if you look on there, it's known as Rezum. This is a technique where a kind of camera is placed in through the bladder. Let's go back. We'll just cover all this. Placed through the bladder, and steam is injected into the prostate tissue to allow that tissue to die and the body to reabsorb it. The advantage of this procedure, number one, we're treating the problem. We're actually removing tissue. So it is removing the obstruction physiologically and physically in and of itself. And the great thing about this procedure, and we'll talk a little bit more about it, is about this lowest retreatment rate. It has literally the lowest retreatment rate of all the minimally invasive options. And we'll come back to that a little bit, I think. If not, we'll cut on the slides. Go to the next one. So the next one has gotten a lot of press. It's called the prostatic urethral lift syndrome, or Urolift. This is a mechanical clip that simply pins the curtains out of the way. In other words, it takes the prostate tissue and pins it back. It is done in the office. It does work for certain size prostate. It does have some limitations, and that's the issue. This one has a lot of limitations based on size. You really can't effectively treat median lobe, in my opinion. Some people argue that with me, but I think if you just look at the long-term data, I win that argument. This is a permanent clip. It is left behind. And if you look at the retreatment rates are about 14%. And because you're leaving a partial clip behind, you do have a little bit of issues that can arise because that piece has been left behind. The next one is laser therapy. So laser therapy is where a laser is used to vaporize the tissue or instantaneously remove it. This is also known as GreenLight laser. This is where the laser basically treats the tissue. It resects or removes the tissue instantaneously, turns it into a vapor, but it does it with a very clean field. You have complete visualization throughout, and that's one of its biggest advantages. It can treat very good sized prostates. However, this is done typically in the operating room. Retreatment rates of anything in the operating are still probably 5 to 10%. However, they're over your lifetime. So a lot of the minimally invasive options are looked at what's the retreatment rate at 5 years. The surgical options are looked at typically what's over your lifetime. This is, again, going to the operating room. You do have some issues with retrograde ejaculation or decreased semen output. It does bring into effect the potential risk of urinary incontinence, whereas the water vapor, Rezum, and Urolift almost do not have that risk. But this is very, very effective. Go ahead. And this is what everybody has heard about for years. This surgery's been around probably 40, 50 years, called transurethral resection of prostate. This is what most people term as the gold standard. Everything in BPH management is measured against this guy. However, there are some side effects from it. You're physically cutting out tissue. It does have some limitations of size on gland. You do have a little bit of scarring issue with this procedure. But again, most of the other options, such as the GreenLight laser that we've talked about, the Rezum, and then the final option we may mention in a minute, called aquablation, have pretty much not replaced this surgery, but have vastly moved it down in most urologists' chain of command or thinking. And then prostatectomy. So prostatectomy is actually physically removing the prostate tissue surgically. Nowadays, this is done robotically. So we go through the belly, go through the bladder, and we simply core out the prostate from the inside. So imagine the prostate being an orange. We're going to go and peel out the pulp on the inside. Now, that's also what we're doing with the laser, what we're doing with the TURP. But when you do it surgically this way through the bladder, you're removing a lot more tissue. So therefore, you see the surgical treatment, retreatment rates are a little bit less. However, it's general anesthesia. There's a little bit more blood loss. Definitely causes some issues with the orgasm. And it's just a much more invasive surgery. But there are still candidates, people with really large prostate. And if you've got a 250-gram prostate, this by far is probably going to be your better option. And I don't think there is a slide on the new one, which is on aquablation. I'll mention it. Okay. Let's just do this one. So this is the I-10 device. It's a temporary implantable nitinol device. This is a temporary device that's placed within the urethra and prostate for about 7 days. As that sits there, it puts pressure through the prostate and creates a groove that the patient's able to void through. Pretty good retreatment rates. I mean, they're 8%. I will point out that that's at 3 years. Most other things you've been looking at are over 5 years, so it is a newer option. It's a temporary implant. It doesn't have a catheter. That's one of its touted advantages. However, size is a big issue with this one. I've done probably some of the highest numbers in the state of Georgia. Was the first one to do it. And again, I've just learned when your prostate gets over 40, 50 grams, you're just asking this procedure to do a good bit of work. And therefore, it's a very subset of patients that you can choose to do this. Okay. All right, so this is aquablation therapy. So this is a automated robot that uses a high pressure water jet to remove the tissue. So that robot and water jet oscillates back and forth, and as it does that, just like a pressure washer, it removes the tissue. Very good retreatment rates. It is in the operating room. It is a resective procedure. Again, we are going to the operating room, physically cutting out tissue. So your general anesthesia, your hospital stay, your scar rates are slightly higher with this. So again, let's just review real quickly. We have minimally invasive options. Those are in office. Those were the Urolift and the Rezum and the I-10, of which the Rezum is going to be the most versatile tool you have. It's going to treat median lobes, prostate, that third lobe, that knee wall I talked about. It's going to treat prostates of all size from 20 to 80. And having the experience I've had, I've actually done up to about 115 grams. Definitely off-label use, but again, it is something that it was my selection and the patient's selections to use in that setting. It is indicated 20 to 80, but it does it very versatile. The Urolift, median lobes are not a good option, in my opinion, and you're leaving a permanent clip behind. And the I-10 is really more for the younger patient with a lot of symptoms and a relatively small prostate. Then you have the findings we talked about. The resected go to the operating room. GreenLight, aquablation. We quickly mentioned TURP, but again, it's mainly GreenLight and aquablation where it's two most common these days. And then the robotic incision through the belly to remove are your options. What's the next slide? Insurance is going to cover all these options. There are some limitations, but everything that I've discussed tonight, probably with the exception of the I-10 device, has excellent coverage. I-10 has very good coverage, but it is the newer of the devices, and anything new is going to take just a little time to get an acceptance with the insurance carrier. Again, I'll summarize that again. Here are therapies. The first line therapy, the American Urological Association does condone going straight to Rezum or Urolift, and I've talked about the pros and cons of those procedures. And again, knowing the size, shape, and pressure will help us determine that what may be your best option. And a lot of times, this patience is about quality of life. How do we help? How do we, make you better? What's your objective? What's your risk tolerance? Do you want to swing for a home run in the World Series? Do you want to swing for a double? In other words, on a good therapy, it's going to last a long time. It's going to have less side effects. And then, yes, maybe I need a procedure later in my life, but I've taken a lot more risk. I think these are all the things that patients go through. And that's where I think when you come see us as urologists, that we should be able to walk you through those. And I always say, arm yourself with information. That's what tonight's about. I am one of the very few people in the state that actually does all these. Everyone that I've listed, I have done within the past 2 years. I've done all but one in 2024 due to the high frequency. So again, having options is always good. I have another saying in my office. I explained to you, how do you choose your procedure? We've talked about that, how do we go through this process? But again, not everybody has to have the same thing. And don't play anymore, but I was decent at golf. I didn't take a 7-iron every day. I could hit a 7-iron, a pitching wedge, or a 3-iron. Distance, I could hit it high or low, left or right, but I took my whole bag. So in BPH, we have a whole bag of tricks. They do really matter on what your goals are, what your size and shape and prostate is, and that's part of the evaluation, just to understand. If we're seeing somebody and I've got symptoms, we're going straight to the operating room, then again, have we considered all the options? Have you looked at your risk and benefits, etc.? Questions on that one? Okay. So I think let's just hold the questions to BPH at the end. I think that's a better way to do this, if that's okay. So the next set of slide is men's health. We're going to deal with erectile dysfunction and urinary incontinence. And this is a little bit of where my passion starts. I have had an interest in ED for probably about 17 years. Actually, Center of Excellence for Penile Prosthesis. And I coined a little saying that I use in my office a lot. It's one of my joys in medicine is giving patients and spouses what cancer thought it could take. In other words, one of the highest incidents for surgical intervention in men for erectile dysfunction and urinary incontinence is prostate cancer treatment or other prostate surgeries. And again, cancer thought it could take your erections. Cancer thought it could make you leak, but not if you see us who do a lot of these procedures in what's called prosthetic urology. So let's run through this. And here comes one of our first slides to take home. And it's, again, if you get in the elevator and you're over 50, do not be ashamed that you're the only one in that elevator that has ED. It's a very common thing. It goes with age. It's about 50% for 50s and 70% of men who are 70 have some form of ED. It really does affect a lot of men, and we're going to talk why that's so important. As a general rule, men don't talk about their health care as much as our lady counterparts, and I hope this changes tonight, because you will find out in this slide that we can actually save somebody's life by talking about ED. Next slide. I think everybody understands how an erection occurs. So we'll go skip that slide. And again, so what are the causes of ED? If you look at the pie diagram inside, you'll see that prostatectomy or pelvic surgery is about 6%. That means over 85% of medications has three causes: vascular, diabetes, and medicines. And what's probably the most common reasons that people take medications? Diabetes, vascular issues. And I mean vascular issues, high blood pressure, heart disease, cholesterol, etc. So again, 85% aren't surgical. So that means there are hundreds of thousands of men in our own community that don't have prostate cancer, that suffer with these issues, that don't know there are options out there. So us guys are going to start opening our mouths and talking. All right. So what are the side effects? And this is why it's become so important to me, because again, we're just wired a certain way, and you got to take that up with somebody else, not done Sharpe tonight. But men who have ED have big issues. They're socially not as adept. They have anxiety, depression. There was a study that looked at men and their interaction within society, their feeling of worthness, etc., and related that to erectile dysfunction. And the men who were unable to get an erection had significantly less interaction in society, with friends, being productive at work. So these are really, really important issues to deal with. And that even is higher for incontinence. So it's really important to, think about ED. Very simplistic society. I like to say urologists are not the smartest medical specialty. We're pretty simple. So if I told you that you have a 4 millimeter in your heart, which is here in the middle of the page, and you have a 2 millimeter artery in your penis, where are you going to have trouble first? Bingo. My 10-year-old gets that one. You're going to have it in the smaller artery. So 93% of men who have coronary artery disease had the ED first. So next slide, I think this goes into that. So if you have ED, you should be evaluated by primary care or a cardiologist for heart disease. That can be done through what's called a calcium score. It's a simple test done by CT. You can pretty much get them anywhere in the greater Atlanta area for probably $200, $250. And they simply look at the calcium score of the vascular system and let you know how that is, to tell you your risk of having having coronary heart disease. And I personally have multiple stories over 17 years. I mean, some really, really prominent ones. And that is most prominent is a 53-year-old who insisted on being evaluated by a cardiologist because his dad died at an early age. And they told him he was fine because he was actually a half marathon runner. This guy was running a half a marathon almost 4 days a week. And they said, you don't need evaluated. When they finally listened to him and he had ED, when they finally evaluated him, they didn't let him go home from the clinic. They admitted him and they did emergent 3-vessel bypass surgery the very next day. So this is why we need to talk to our sons and our dads, because again, this really can save somebody's life. So very, very important to talk about that and understand the correlation between erectile dysfunction and silent heart disease and the need to be evaluated. So ladies out there, if this is an issue with your partner, please have them go see them if you like them. All right, ED and Peyronie's disease. So Peyronie's is simply just a curvature of the penis due to a plaque, as you see here in this. And what happens is the bottom side of the penis gets erect, so it stretches. The top side gets erect, but it does not stretch. Therefore, in this example, the man's penis curves up. It's typically due to some mild minimal sexual trauma. Most people do not remember this event. And again, it can cause significant issues with erectile dysfunction and is treatable concomitantly with erectile dysfunction or at the same time. So one of the options that we talk about will actually treat both these diseases, erectile dysfunction and Peyronie's disease, at the same time. So Peyronie's disease does have several options. They basically right now, the mainstay is injectable medicines into the plaque. Historically, some of the older medicines, steroids, oral medications have not been very effective over the mass of patients treated. Therefore, we typically talk about an injection into the plaque. That's called Xiaflex. Surgical options, you can actually excise the graft, excise the plaque that's causing the curvature, as you saw in that man's penis earlier, and then replace it with an artificial graft, and that will allow tissue to simultaneously move and therefore give the straight erection. The other option is what I call a pulley stitch. In other words, if the penis is curved one way, a stitch is placed on the opposite side to simply straighten the penis. However, in a lot of patients, when they have both of them, they have ED and Peyronie's, we look at a penile implant system. And the reason is because if you're going to do surgery to fix the curvature and you have ED, you're going to the operating room and taking all the risk, and you're only fixing half the problem. And it may not be the half that causes most of the distress with the couple. So you can implant a surgical device inside the penis. This device is completely underneath the skin. No one ever knows it's there. There have been over 1 million placed. As someone who's had a special interest about 17 years, done hundreds of these, and I always look at men and say, you know somebody that has one in place, you just don't know it yet. So again, this device will overcome both the erection and straightening of the penis as it is become erect. So let's go just the basic ED options. I think most of us know that. Again, there are things to look. Primary care can treat. That's oral medications typically. You've got your normal urologist who treats probably some ED, and they do medicines. They might do injections or whatnot. Then you have a prosthetic urologist. That's someone who has a special interest in erectile dysfunction and also prosthesis that can help that. So they run the gamut of the treatment options and typically treat a lot more ED. And also, if you just look at volume, volume matters. The more they do of something, the better they are. So especially if it comes to men who want to kind of fix the erections and not deal with this any longer. Those are going to be the ones you want to kind of see. I'll probably stay here just a second. I can most of these. The oral medications, everyone knows about those. Everyone knows the Viagra story. No one returning the medication. When the study for hypertension, sildenafil, was closed in Europe, however, nobody turned their medicine, and that's how Viagra was discovered. A vacuum erection device. That's a device over the outside of the penis. You press a button, usually battery operated, and it makes the penis erect. Now, those are used in two ways. For those of us who do a lot of these surgeries, prostatic urologists, we're typically going to have you use this device for stretching before. So you can use this as a stretching. So if you're a man that says, look, I don't have quite the length and girth that I had when I was younger, when I was getting normal erections, I was more active, this device can be used to stretch before any treatment option. And then, like I said, you see in the bottom inset circle here, it has a band around the base of the penis. And this keeps the erection through sexual intimacy. And then finally, injections. Injections, they don't hurt. That's the most common. Oh my God, it hurts. I tell people it's going to hurt a whole lot from about right here up. In other words, it doesn't hurt anything from here down. It's a diabetic needle. Diabetics do reasonably well with this because you're used to injections. And then the penile implant. We're going to come back to that one in a second. Next slide. Medicines are not next slide. Are not a free pass. They have medication. They have side effects: headache, facial flushing, Cialis, a little bit more of the upset stomach. But these have been around a long time and are good first-line therapies. We talked a little bit about this real quickly. Again, we're going to have you use this device for cycling. So again, I tell people to cycle that 4 erections a day, once a day. And that will allow the penis to stretch. And one of those cycles, you want to let it stretch for about 5 minutes. So if you're suffering for ED, this is something you can get tomorrow. I do highly recommend battery operated medical grade. You do have a lot of these devices out there. The cheaper ones tend to last and doing this for a long time. So it's one of those things that probably just a little bit better to get a better device and to be reliable. The injections do work very well. The erection can last longer than the typical 3 hours. So that sometimes can be an issue. You can get some discomfort. I usually tell about 10% of people will get what I call a migraine of the penis. It is this. If you've ever had a migraine, you know what I'm talking about. It's that throbbing, can't think anything else about it. of the penis from the medication. It is pretty low. I do definitely encourage everyone to try this. Most people don't do it long term just because of the medicine sometimes can go bad and be labeled, and you don't, it doesn't last in the refrigerator. It can cause some scarring tissue, so it can cause curvature. And then the cost. So every time you have intercourse, you've got a cost associated with it. Next slide. The last one is the penile implant. Okay, so that is a device implanted into the penis. When you want to have an erection, there's a device you see in the scrotum that is pumped. As that is pumped, the penis becomes erect. I'll have a little video in a second. And then you're able to successfully have intercourse until everyone wants to stop. So that is an advantage that almost every couple in doing hundreds of these will tell me that they appreciate. That again, now they're able to continue with intimacy through the duration that everybody wants to participate. About 97% of men would recommend this to a friend. I have another saying, if there was something, if Ford had a 96% patient satisfaction rate, there would be no Chevy, there would be no Dodge. In other words, it is hard to beat, and it's inappropriate not to tell patients about these because, again, they have such a high satisfaction rate. At the end of the day, we can talk a little bit more about it during the talk here, but I say ask yourself the following question, and that is, if any of us were to be working outside and fall and have that hip fracture or that knee surgery that prevented us from walking and working in our yard, going on walks with their spouse, doing something that we enjoy every day as a quality of life issue, would we have a knee replacement or a hip replacement in order to enjoy our life? And I think in today's world, everybody would say yes. There are hundreds of those put in every week in the 2 hospital systems that are close to us. So this is something very common. And I turn around and say, well, you should think of this no different. It's no different than a pacemaker, a hip replacement, knee replacement. In fact, actually, penile implants are more satisfying, they're less infected, and they typically last longer than all 3 of those issues. And again, the pacemaker, who wouldn't have a pacemaker to be able to go on a walk without their heart fluttering or going into some arrhythmia and causing them discomfort or pain or inability to walk? Of course we would. This should be sought as no different. And the other reason I will say that is because, again, if you just look at couples who continue to maintain intimacy throughout their marriage into older years, they live better, they have a better quality of life, they actually live longer, and they have less issues of depression, suicide, etc. So it's very important as a quality of life measure to look at these devices as options. You can see here, this surgery has been around. The 50th year anniversary was, I think, 2 years ago. So these have been around for a long, long time. This is the AMS device, or the Boston Scientific. This actually, you see it's kind of brown. It is encoded with an antibiotic, which will then form an antibiotic layer around this device, protecting it. It's a very, very rigid erection. It's very soft when it's soft. It's very firm when it's firm. Sometimes patients get to choose rigidity. It's a well-known fact that if you have this device and you're younger, as couples get older, they may choose to adjust the rigidity for both partner and patient. So again, an excellent device with a 96% patient satisfaction rate and a very, very low mechanical failure rate. This is a mechanical device. They can fail, but that is literally about 6%, almost over a decade. I think the study actually was 7 years, but the longest I've ever seen one of these work is a patient of mine currently. That's 27 years. It's still working 27 years later. The diabetic had put in a very young age. So these can be put in for all different reasons: diabetes, spinal cord injuries, had prostate surgery, had a heart attack, and now I'm on medicines and Viagra's working great. Now it doesn't because I had my heart attack, or I'm on a new medication. So think of this device no different than you do almost anything else that improves quality of life. No one ever knows these devices are there. As I said, somebody that has one in place, you just don't know it. So drops that message home. And it's not something that you interact and feel with every day. Before we show the video, I say, listen, if you have a knee or hip replacement, You don't go on that walk and every step say, I've got a knee, I've got a knee, there's my knee, it's in my right leg. It's just part of you, and that's what this device becomes. So I'm gonna click the video and kind of show this will demonstrate exactly what is gonna transpire if you have one of these devices. Again, it's underneath the skin, nothing's seen, no one will ever know it's there. If you're a man and you're working out, no one's gonna know it's there, even in the locker room. So with intimacy, a man will reach down between the testicles typically, and he will pump the device. As you see, water is transferred from a little reservoir behind the pubic bone into the penis. The penis becomes erect. Again, it will stay erect till everyone wants to stop. A different button is pressed and held for 4 seconds, and the erection will go away on its own. This video shows them holding a little longer, but it's typically 4 seconds, and the device will go down on its own. It's an on-demand situation, so it returns intimacy, the flow of intimacy, almost as it was when people were younger. There's no planning, there's no interruptions. I need to go do this or that. Location independent, etc. Let's see. I think this is pretty. I think we kind of covered most of this stuff. Get to some of the questions. But really quickly. Typically, I will tell you 1 to 2 weeks of some discomfort. I joke a little bit and say no one likes me the next day, but everybody wants to buy me dinner at 6 weeks. And that's just a little Sharpism, as some of my support staff call it. But the point is, it drives the message home. You go through it. Once it's over with, you don't think about it anymore. And it is extremely rare. And it's actually probably been years since I've had somebody say, look, I wouldn't go through it again. Independent of the course they had. And I just saw him this week. He's probably the most convoluted course to a working penile device that I've ever had in 25 years of medicine. And he said I would do it all again because his device works, he's happy, little bumps in the road, but he tolerated those well. And that just goes to show you that these devices do help and are very satisfying for patients, partners, etc. Again, it is hard to argue with these numbers. I think they speak for themselves. We talked about it. And depending on, this is just one study, depending on who you read, I mean, it's still consistent. Like 92 to 98%, almost every study with these devices, independent of manufacturer, independent of surgeon, and especially high volume surgeons, people are exceedingly happy with these devices. Okay. It's covered by insurance. We will help with that at Georgia Urology. Some experts in that who help with that, and even special situations, but almost every device is covered by insurance, especially with Medicare. So Medicare covers them all. Supplementals pick it up. And then there are other options if insurance doesn't cover it, but that is a rare situation. Okay. We talked a little bit about the risk. I mean, I tell it, it's about 1% across the board. Injured to the urethra, infection, mechanical failure, we talked about that. So nothing in surgery has zero risk, but when you look at the risk of this surgery are actually less than knee or hip, then I think it puts it into perspective. Great website, edcure.org. It is .org. These are some QR codes you can scan and get information, learn more. I think everyone on this video may get this in audio. Please feel free to share it with individuals. And if you do that, mainly let's just do it for erectile dysfunction and its association with coronary disease. I think we're going to touch just real quickly on a little bit of incontinence. Real quickly, as I said, I enjoy giving men what cancer thought it could take. So next slide, stress urinary incontinence, not a very common issue in men, but does occur, typically always related to prostate cancer surgery. There are 2 kinds of incontinence, urge and stress. We're mainly going to touch on the stress component. And that is when you cough, sneeze, run, lift, etc. Next slide. And we talked about this, the mechanism to keep the urine dry is the sphincter muscle just below the prostate. Next slide. And that can sometimes get injured with surgery. I think we talked about this, surgery, radiation, urethral strictures, etc. Some BPHs, typically BPH surgery, we talked about earlier about 1% incidence of urinary incontinence with any BPH treatment option. Quality of life is off the chart here. This is, in my opinion, the most satisfying surgery in all of medicine. And that is when you take a man who leaks, and that's typically with artificial urinary sphincters, and make them dry again. It is like you have a new patient. Next one. And again, incidence probably, 5 to 15% don't need read, may have some leakage after prostatectomy. Usually, hopefully, this is pretty mild, but still all fixable. Next slide. I think we understand this. Next one. Now, there are behavioral modifications. Pelvic floor is key. I think we talked about that. For some reason, the vacuum erection device actually helps a little bit with incontinence. I've found that over my career. Pads, next line. And pads are not benign. Pads are costly. They're expensive. People have accidents. They increase your risk for urinary tract infection. Urinary tract infections sometimes in elderly patients can get admitted to the hospital and have significant complications. So fixing urinary incontinence is very important. This is a male sling. It's similar to a female sling. However, it is different. It is not the worry you should have with mesh type material. Mesh is used every day in every hospital. The system works very well. The nice thing about it is you're dry pretty much when you leave the operating room. And you get to go home the same day. By the way, you do go home the same day with penile implants. Typically, those can be done hospital or surgery center. Same thing here. These can be done in both places. And you see the sling is placed underneath the urethra to provide normal control. Next number, it's a mechanical device, not a pump device. So that's why you get the continence immediately. And then you have an artificial urinary sphincter. Next slide, I think depicts it better. This is a system which wraps around the urethra, a very pump mechanism like the penile implant that will always stay on. That device will close down in the urethra. As you see it wrapped around the urethra. When the man wants to go urinate, he presses the control pump that releases the pressure. He's able to void in over 60 to 90 seconds. That cuff around the urethra will fill back up and then allow the man to be continent again. Next slide. And I'm going to play this. I mean, this is just the same depiction. Again, man wants to urinate. He goes to the bathroom and presses this little small control mechanism 3 simple times. As he does that, and here in just a second, it will 3 small pumps. It opens the cuff, and you see the smaller window there. Opening that, urine flows out, and then the cuff closes back. So this allows the man to stay dry and pad free. So most of us prosthetic urologists, we have a little comment say to live life dry. Leaking is a choice. You don't have to leak. Those of us who have special interest in that can help. Very similar. You can't, the artificial sphincter, you can't use the device, so you still do have leakage for about 6 weeks, but with the sling, the hope is you're dry the next day. Discomfort is pretty minimal with both these procedures. It's just you feel like your legs have been stretched a long ways out, especially with the sling. So that pulled groin concept that you may have, you've had athletic sport injuries, is what most people feel like, and it's just that irritation of the sling being placed through the muscle. Again, what I quote, this is a new updated slide, but the last slide I looked at, so it was a 98% satisfaction rate with men with artificial sphincters, because it literally allows the men to go out of the house. I've seen men come in who are disheveled. They wear sweatpants. They don't interact with anybody, have a sling, and they're back on the golf course and back in church and doing their normal life and living life to its fullest. The oldest, I'll do this the same for penile implants. I forgot to cover this. The oldest implantable device I've ever done, the patient was 88 years old. So this can come the gamut. I put them in 20-year-olds, I put them in 88-year-olds. So just because you're of a certain age, don't feel like you're not a candidate for these options. You are an option. I don't treat a medical age, a chronological age. I treat a medical age. So again, be evaluated, live life dry, return the quality of life, and know there are options out there available to you.